Hi, everybody. Welcome to the very friendly Western Village Rotary Club. And to those zooming in, Chris and Diane, welcome.
You also have Sean McMillan and Jackson.
And Sean and Ed. Chris.
Hello.
Okay.
Hello.
Hey, Sean.
Good to hear you, Ed.
Yeah, thank you. It sounds great. So look forward to seeing you sometime soon.
This year we're celebrating the magic of Rotary. Okay, why don't you read us the four-way test?
The four-way test of things we say or do. Is it the truth? Is it fair to all concerned? Will it build goodwill and better friendships? Will it be beneficial to all concerned?
Thank you. Thank you, Peter Moore, for greeting today.
We've got the president sitting at the table because he doesn't understand that there are questions with him.
Shouldn't we lead us in the pledge?
Is this coming Monday. And it's a national celebration of the social and economic achievements of the American workers. In 1894, President Grover Cleveland signed a federal law making the first Monday of September Labor Day. 30 states were already observing the first Monday of September as Labor Day. The last day, traditional end of the summer, the last day to wear white is Labor Day, since summer vacation is over and time to return to work and school. So then, no more white sneakers.
By the way, either that or blacks, the only thing I can slip into.
Okay, fair enough. We got a presidential dispensation.
Okay.
Since the country says you're president. Labor Day has become an important weekend for sales by many retailers in the U.S., especially back-to-school sales. Some retailers claim that, other than Black Friday, it's their best sale day. I thought it'd be appropriate to share 3 Labor Day quotes from well-known Americans. This is what President Theodore Roosevelt said: "Far away, the best prize that life offers is a chance to work hard at work worth doing." And here's what Martin Luther King said about labor: "No work is insignificant. All labor that uplifts humanity has dignity and importance and should be undertaken painstaking excellence." Lastly, Wayne Gretzky, the hockey player, who was probably the best hockey player who's ever been in the NFL. Excuse me. Let's begin. The highest compliment that you can pay me is to say that I work hard every day and I never dog. Anyway, happy Labor Day, everybody.
Involved. Song, please.
Yes, yes.
Put my glasses on. Gordon, would you come up and
Stand up.
You wear that suit in the shower?
Marvin Hatton?
Wear a suit all the time.
Did I see you yesterday?
Yes.
Was I wearing a suit? Okay, thank you. The reason I called, quiet. The reason I
He's
called,
speaking.
somebody else was speaking.
I said you were speaking.
No, the reason I called Gordon up, he's the second best dressed man here. Look over there.
I'm not there.
Today we have a short song, and it's a Civil War song, and it's the Battle Hymn of the Republic. Will you please stand, sing it? And as you know, it's a Civil War song, the blue and the gray, so I have hats worn by the blue and the gray.
That's good, thanks.
These are Civil War hats.
I'm blue.
I'll take a picture of this.
Sure, why not? Okay, let's go. All right.
Good ass.
I'm reminding you that you're doing the windmill today, thank you.
We have any visiting Rotarians?
Yes.
Please, introduce.
I will stand up for this. I want to introduce my first lady, Canada Gloves First Lady, Susan Dager, Fisher. Welcome.
Delighted to have you. Sorry, any guess? There you go. Welcome.
Tell us a little bit about you. Okay, I've lived in Los Angeles 30 years, and I had a career working for a wealthy businessman and celebrity here, and I am currently getting back to practicing my artwork, which is my background, yeah. And I heard about Rotary quite a bit from Nancy here, whom I had met almost a year ago, or not ago. And I just feel really pleased and grateful to be here. Yes.
The wealthy businessman and celebrity that you worked for, was his name Steve Shear?
It's Michael Jackson.
Okay, we have a couple of announcements. October 2nd through 6th, the first humanitarian trip this year to Maui. As you can imagine, space is limited, so if you're interested, please sign up now. Then we have our annual foundation gala, and this year it's going to be on November 2nd. And that's going to be at SoFi Stadium. If you haven't had a chance to visit SoFi Stadium, it's truly extraordinary. And then this is a wonderful opportunity, and that'll be from 12 noon to 4 p.m. So please talk to Steve, he would like to make.
Sure. Yesterday I sent out an email about the event tickets themselves. Already about 9 of us have indicated they're going to go. Some have indicated that they're hoping to go, just a matter of checking with their significant others. So please let me know as soon as you can if you want to go to the event itself. It's $150. It's at SoFi, and as Chris said, it's really quite a facility, and it's a great opportunity to take a tour of SoFi, as well as a nice luncheon and the usual silent and live auction and the raffle tickets. And already, guys, We've done really well. An email yesterday said we raised last year $6,900. So far this year, we're already up to $5,300. So I really thank some of you today. I got a limited number of them from the district. They're promising me a lot more of the raffle tickets. They look like this. Please fill out the bottom portion of it. Chris gave me some money earlier for his tickets, and I told him since he's presiding today, I'd fill out the bottom portion, which is what you returned to me, and I give these back to Chris, and I get these. So fill them out and turn them to me with your check. As I said in my email, if you want, you can charge through with a credit card to Rotary Foundation. Important, as you do that, don't just log out. Make sure you print the confirmation, because you won't have a later opportunity to get a confirmation. So make sure you print that out if you want to use the online credit opportunity. Otherwise, just write a check, Steve Day, and you'll be fine. The Rotary Foundation, for however many, how much you want.
You got the booklets available right now?
I just passed them out to some people, Tom. I'm sorry to give you one, but I'll have them. Tori tells me in very short, we'll have some more. So don't hesitate writing the check. We'll make sure your book will be there. If by chance, I'll do it if I have to. Otherwise, but I'd like you guys to fill out, you folks to fill out the books. So, yes.
Are they going to do a tour for part of this time and organize it?
I believe they are. I'm getting confirmation of that from Tori. She said she was hoping to send out kind of a detailed email today to everyone about the actual event, but from what I hear, the tour will be part of it.
Right.
So that's what I'm hearing. I just want to confirm that here. Gordon?
I've got a question. When we give you the stubs and you fill them out, who's
Yes.
name you put them on?
Well, this one I put on, you see that's what, they almost all say Chris Gaynor.
Steve, what are they doing about parking?
I don't know yet. That's a great question. I think there's some cool parking there, so they probably will tell us which lot of those are. And that information should be provided, but I'll.
Yeah, that's a big, it's a huge area.
It's a big area, absolutely. Right. They'll probably be right. Yes, Ed.
Are they having an outside speaker?
I don't know exactly who the speaker is gonna be.
Are we gonna, did you mention we're getting an itinerary or?
Yes, that's supposed to come out real soon. Like,
Okay.
I'm supposed to come out before lunch today, actually, but I just checked my phone, I didn't see it. It's gonna be in an area, Ben and Susan, when we went and saw the Rolling Stones, and we had our dinner, it was in that area, outside that patio area. That's gonna be the Gallagher courthouse. Courthouse, so the courtyard, that's the road research. How's that be fun? Anyone, any other questions? Okay, anyway, that's it. So hope to see you all again. And I thank Mark and Lynn Rogo for hosting their own table. So it looks like with Rotary, Westwood Village Rotary, we should have 2 tables there at least. Like I said, one that Mark is not hosting, we've almost filled that table up already.
How many are there?
Good. Okay, thanks, Chris.
Thank you. We have some birthdays. Phil Gabriel, August 19th, happy birthday. Jim Crane, August 30th, happy birthday. Always think I'm happy birthday?
Yeah.
We have some anniversaries. These are pretty impressive. We'll start with Terry White, August 6th, 8 years. Benjamin and Susan, 10 years.
Yeah. I'm gonna find this. Jerry Live.
What?
Jerry Live. This should have been
Wrong there.
anniversary.
Yeah.
All right, yeah, well, I can speak for myself, that's right. Rosa and myself, 43 years. Gordon Fell, 44 years. And Steve Shear, 54 years.
Wow.
Congratulations. out the alcohol hater. Okay. I need some help with this, Bill.
I would say this is a community joke.
Okay. Why are you doing that?
Sorry, I just need to.
Large Texas, 10-gallon hat, gold nugget bowl, tie, big silver belt, fancy alligator hide shoes, walks into a bank, strolls over to the teller's window, and boldly states, I'd like to open up me gosh darn friggin' bank account.
I beg your pardon, sir?
Let me say it again. I want to open up gosh darn friggin' bank account.
One moment, please. There's an email out there who wants to open an account. Pick it up.
There's money like coming again.
I said it was and then you go out.
So, what was that? Lady rude to you? It's hard to read the whole thing. That was my third mistake.
You know what? I have another joke.
Plan B.
Try it, Chris.
Country store in the middle of the French countryside. And all of a sudden, a large supermarket opens up next door. And a sign comes up, and it says butter, 10 francs. And the little lady who owns the country store, she comes out the next day and puts up butter, 8 francs. And the next day, big superstore has another sign coming up, 7 francs. And sure enough, comes out, puts up a sign reducing it, 6 francs. Once again, big store comes out with another sign saying 5 francs. One of her customers comes up to her and says, Madam, how in the world can you compete with such a large store? You're not going to make any money. You know, they can undercut you forever. And she goes, Monsieur, I don't even sell butter. Okay. Yeah. Will you introduce our speaker?
Yes. Everybody, I would like to introduce our speaker for today. Dr. Adam Wiener is an MD and urologist at Cedars-Sinai Medical Center, adjunct assistant clinical professor at UCLA. He obtained his bachelor's degree from Yale, we got a smart guy here, and a degree from the University of Chicago. He then completed his urology residency at Northwestern Medicine in Chicago. Dr. Wiener's urology practice and research focuses on patients with prostate. We agreed that even though this may be depressing, it's something that we need to look at, right? All of us are gonna have, we all have problems. So, he's gonna try to make it as funny as possible. Okay? And so, with that, on a personal note, Dr. Weiner lives with his wife, and 2-year-old daughter in West Hollywood. His wife's name is Amita Reddy, and she's also a surgeon at Sears, specializes in pediatric ENT. Julie's busy, professional, and family life. Dr. Weiner's favorite hobbies are weightlifting and acoustic guitar. Let's give it up for Dr. Weiner.
Thank you for having me come and just witness the business matter of things. It's just great to see all of your personalities, and I think y'all have a wonderful group. Thank you. And great, and just great jokes. So I'm going to talk about a subject that I think is very important, in particular to this group and this age group. It's about prostate cancer screening, and I'm going to break it down in a really simplistic way so that even if you get a fraction of the information that I'm going to go over, it's going to help a ton to just fill in, all the questions that most people have regarding prostate cancer screening. A bit of an introduction for me. I guess I can skip over most of this because of a wonderful introduction from Benjamin. I work over at Cedars now. I see patients here. I do research here at Cedars and at UCLA. I have a lab there that's funded by the Prostate Cancer Foundation and the Department of Defense. So when I think about prostate cancer, especially from someone who's coming from it, not from the medical community, so a couple of people in this room, I think I like to break down these problems very simplistically. Understanding what you're dealing with, when to deal with it, how to deal with it. If we can get through those things, and I feel like today's talk will be a success. So let's start with the what you're dealing with. Okay, what is the prostate? And I'd like to start here because I can't tell you how many times this is the first question that I go over with patients when they come to see me for the first time in the office. So the prostate is it's one of the male sex organs. That's where the ejaculate comes from. It's about the size of a walnut, and it sits in front of the rectum and under the bladder. This small, sorry. No problem. There we go. Okay, perfect. Okay, one moment. That's the prostate right up there. Tiny walnut-sized organ. The urethra, the tube that drains urine from the bladder, it goes right through the prostate. And all of that is important to understand as you kind of think about prostate health. So I think if y'all got these facts in terms of anatomy and what it does, that's pretty much all you need to know. So let's focus then on prostate cancer. As many of you know, it's a very common cancer. In the US alone, annually, there's going to be more than 300,000 new diagnoses. These are patients who have a new diagnosis of prostate cancer. It'll account for over 35,000 deaths. Again, this is just in the US alone. And you can see how, in this figure, how it stacks up to other cancers. It's the #1 most common cancer of men, and then it's the second most common cause of a cancer-related death in men in the US. Right now, there are over 3 million people in the United States living with a diagnosis of prostate cancer. So they might have been treated for it or they're being treated for it, but they were diagnosed in the past. This is a common murder. I'll pose this question to the group before I reveal the answer, but does someone want to give a guess to the average age when prostate cancer is diagnosed in the US? Let's hear 1 or 2 guesses. Yes.
62.
62 and 60. 60?
75.
Okay, so we're getting in, we're in the 60s, we're talking in the 60s, and you all are spot on, it's 67. 67 is the most common age. And again, that's the average. So we're talking about there are plenty of people diagnosed before that age and then plenty after, but that's the most common age range. I want, yes?
Is it okay to interrupt with a question?
No, of course, no problem.
The average age 67.
Yes.
How many have it before then, or what's the spread of that? That's the.
Yeah, I would think about it like We'll get into to the screening age range, but the most typical time frame that it's diagnosed or that it becomes important is usually between 45 and about 70, 75. So that's why 65 kind of ends up right in the middle of that, what looks like a bell curve at the end. Got a nice bell right here, you kind of get the idea. Yeah. Stages of prostate cancer. This is very basic. Again, I feel like if I get these points across, then this will be a successful talk here. So it's a small cancer in what we call low grade. So when they look under the microscope, the cells themselves don't look that aggressive. We call that low grade. Those patients who are diagnosed with that can, the typical treatments are surveillance or even something called focal therapy, where maybe you buzz it with a laser or you freeze it. Those are really only for the very small, low-grade cancers. The most common time that we diagnose prostate cancer is kind of right here in the middle. It's larger and higher grade, but it's still confined to the prostate. It hasn't left the prostate. That means it's not metastasized. Lose the prostate, that's called metastasis. The most common treatments for those patients are radiation with or without hormone therapy, or what I perform is surgery to remove the entire prostate. And then there's one of the less common but still possible ways that prostate cancer is diagnosed when it's spread outside the prostate, so it's metastasized. At that point, it's not something that unfortunately not curable anymore, but we do have medications that are very good at keeping patients alive now at an average of more than 10 to 15 years. So just because if someone's diagnosed at this stage, it doesn't mean it's the end of the road, because we're so good at treating prostate cancer now. But I will tell you that our goal is to diagnose people right here in the middle so that we can cure them with radiation or surgery, but we also didn't diagnose them so early that, they don't need a treatment. We really want to find cancer that's in this middle of the road. Now, I mentioned the grading, right? So there's low grade, there's high grade, and you kind of get the idea that if you go from the lower grade tumors on this diagram here that's at the top, and you go down to the higher grade, those tumors that are higher grade are just more aggressive. You need to have more treatment. You need to be aggressive about what you do with those cancers. I want to bring this slide up because historically this is a very confusing point to patients. So the old scoring system for prostate cancer was called the Gleason score. If anyone's familiar with this, you might have heard some of these terms: 3 + 3 = 6, 3 + 4 = 7, and so on. That scoring system is kind of ridiculous. It went from 6 to 10. So you're telling me that you're going to tell a patient they have a low-grade disease and it's a 6 out of 10? That doesn't make any sense. So about, I want to say 8 years ago now, they totally revamped it, and now the scoring system goes from 1 to 5. Way more intuitive, I would say, right? So if you're seeing me for the first time and you're talking about a new diagnosis of prostate cancer, I'm going to give you one of these, because 1 through 5, because that's just going to make more sense to a patient. 1 is not aggressive, 5 is more aggressive. We've stepped away from the 6 to 10, but I like to put this up there because historically, this is important for patients. So now you're armed with a good amount of information there. Okay, went over yes.
I'm sorry. The 1 to 5, isn't that true with all cancers now?
Say that one more time.
And the 1 to 5 scale, isn't that true with all cancers or something?
So there's a staging system that generally goes 2, 3, 4, and that is for every cancer. And that's more like what I was talking about here. So these ones over here are 1s. These ones in the middle are 2, and then these ones off to the right are 3 and 4.
Okay.
Yeah, this is what the pathologist sees when they look under the microscope on the tumor cells. Okay, so I think now we have a clear idea of what we're dealing with. And we can certainly go back if there are any questions, but now when to deal with it. This is kind of the crucial action point. How do you empower yourself when you're not dealing with what you're dealing with? Screening for prostate cancer. First off, let's define screening. What does that even mean? It's actually quite a a nuanced term. It's testing for a disease when someone has no symptoms related to it. I was just talking to someone a moment ago about they felt they were having new urinary symptoms that got them concerned about prostate cancer. Actually, prostate cancer is most commonly diagnosed before someone has any symptoms. If you have prostate cancer, most commonly it's not affecting your urinary symptoms. And that's why we screen for it. Because you're not going to feel a lump or bump, you're not going to feel an itch, you're not going to feel a new symptom. That's why it's important to screen for prostate cancer, because it's asymptomatic for the most part. There is a history of controversy regarding prostate cancer screening, and I think this is another point that is crucial for patients to understand why. So I'm going to go through a bit of a timeline here, but I've summarized it in big letters here. Essentially, in the 90s and into the early 2000s, we had a blood screening test called PSA, prostate specific antigen test. And this test was basically implemented for anybody, pretty much anyone in their 30s, 40s, and then up until their 80s and 90s. And we were screening too many people that it wasn't worth screening. And then, what we saw is that too many people were getting treatment for prostate cancer. And unfortunately, a lot of those people did not benefit from that treatment. And I'm going to go into that reasons why. So because we were screening too many people, and you see this huge bump in prostate cancer diagnoses in the 90s going into the 2000s, some federal guidelines came out that actually said that we need to stop screening people. It's causing way more harm than good. So around that time is when I started residency training in urology, and I started becoming interested in prostate cancer. And through part of my research, I found that as a result of those screening changes, the diagnoses, static, uncurable prostate cancer actually increased because we were no longer screening. We weren't looking for it in people who were asymptomatic. So then we were beginning to find more people who had uncurable disease. The cat is out of the bag, unfortunately. And unfortunately, this was mostly affecting older men in their 70s and 80s, because if they had been screened in the past, they probably could have been caught 5 years ago before the cat was out of the bag. So this, along with a reanalysis of some of the earlier trial data, allowed us to understand that PSA screening actually did benefit patients. And so that brings us to the 2010s and current. Now we understand that we just have to use PSA in a smarter way, and I'm going to go into that so that we catch people who are going to benefit from treatment, and we stop screening in people who are not going to benefit from treatment. So let's go into that. I just covered the controversy, but now let's talk about when we actually do prostate cancer screening. The typical recommendation is that you start in ages of 40 to 45. These are men with risk factors. Or 45 to 50. This is your typical man. What are risk factors? Well, we know that prostate cancer is diagnosed earlier and more aggressive in men, Black race or African American ancestry. There are some mutations that are common, but those are the men who have a higher risk of prostate cancer. I don't expect you to memorize these, but it's one of those, if you know, you know. Because if you would have been, someone else in your family would have gotten one of these mutations because they had a cancer diagnosis. I don't expect you to go out and get this test all of a sudden. It's kind of it's intuitive to someone that has one. And then finally, a family history, but that's confusing. What does that mean? Is it your dad's brother or your dad's cousin? I want to make that really simple. If you have a first-degree relative who is diagnosed with prostate cancer before age 65, so that's a brother or your father, then that's a family history, and you should start taking a screen earlier. If you have a first or second degree relative who was diagnosed with metastatic cancer, prostate, breast, ovarian, or endometrial, that's the inner lining of the uterus, that's also a risk factor for prostate cancer. So that's a real simple way of looking at family history. So any of these risk factors trigger you to get diagnosed, to get started screening a little bit early, but typically you should get started by age 45 or 50. The next most important question, we know when to start When do you stop? Well, typically this stage is around 70 to 75, but we now know, of course, and acknowledge, not every 70 to 75-year-old is the same. This is just a, funny cartoon image here, but you can tell this guy was out here running marathons at 75. He's a different patient than the gentleman on the left. And I want to make that really clear. If someone is healthy and fit, even at 70 and 75, and they look like clearly this guy's got another 10, 15 years ahead of him, that person can probably still benefit from prostate cancer screening. So I don't like to say just typical age. I like to be very clear. If you're a very fit, somebody in your 70s, you can still continue screening, okay? Because if you find a cancer that warrants a surgery or radiation, you can benefit from treatment for that, okay? Any questions about that? Because I think that's an important point for the speaker. Yes.
When you go to a internal medicine,
Yes.
typically every time I have a physical, he's screening,
Yes.
PSA test, and a very uncomfortable finger.
Yes.
So to speak, we were talking on the way over, is that finger still the product?
Can I get back to you on that? Yes. Yes.
Maybe I just did, or it wasn't totally clear to me, what the risk is of testing your blood for this ESA.
The risk of the blood test itself. Right.
What are we gaining by not testing if it doesn't show up, what have we lost?
Exactly. And I'll go back to this earlier point. In the 90s and into the 2000s, we were screening too many men and then biopsying too many men and then treating too many men. We've learned a lot since then. We now screen at a certain age range and we stop screening at a certain age range. Because if you're older and you have other medical issues, you're not someone who's going to benefit from looking for an asymptomatic.
So the prostate test isn't necessarily, but it's a determinant.
You mean if you have, does it tell you if you have a cancer or not? Not 100%. Not 100%. It tells you you have a higher risk of having prostate cancer. But again, if you're, say, you're 85, and you got many medical issues like heart disease or Alzheimer's, that's something that you don't really want to put through the screening. Because, okay, say you find a low-grade prostate cancer, you might not even treat it. And so you kind of went through the process unnecessarily. We're trying to spare that now. At least now we do that much better. Yes.
Can you go to the next slide?
Sure.
The next one. You had two people. You had one guy with a.
Oh, Mr.
Oh,
Moran.
yeah, that's on the left. I mean, he looks old because he doesn't do marathons.
Yes.
Suppose the guy on the left is a heavy smoker
Yes.
and a heavy drinker.
Yes.
What role do those two factors play in the incidence of prostate cancer?
So we do now, as far as other things that can affect the development of prostate cancer, there seems to be a link between smoking. The link with alcohol is less clear. There's been some data that show that it actually has a protective effect, but does that really mean much of anything? No, it probably just means that it doesn't affect prostate cancer. Smoking, yes. Though.
Okay.
Yeah. What about diet? Diet, can I get back to that one? Yeah. Yeah. Finger and diet are coming up. Okay. How to deal with it? Okay, so a little bit more about the test itself and some of these other questions. If you haven't started prostate cancer screening and you're in that age range, the first step is just to talk to your primary care doctor. They are the gatekeepers and they have this concept in their mind about whether or not it makes sense. This is what's taught to them now. And when I lecture the primary care doctors, we're all in agreement that if someone is healthy and they're in that age range, then they warrant prostate cancer screening. So that's the very first. Some other things that you just educate yourself. So I mean, I'm really happy that y'all invited me here because I think these are the important discussions to have. If you educate yourself, you can determine whether or not prostate cancer screening makes sense for you. I have two educational resources up here. One is the Urology Care Foundation. It's probably one of the most common ones. Rather than anything urology, but specifically prostate cancer. And then I have a website too that, well, if you pick up one of those papers that I looked at the front, you can get the link to that too. You point your cell phone on the card, at the QR code I have here on the paper. Okay, so let's go over some facts about prostate cancer. First, the finger. So, we mentioned on the phone, I was recently interviewed for Slate Magazine because it's become clear that we're getting away from the rectal exam for prostate cancer screening. So I want to just put the facts there, and you can look at this article as well. So it used to be before there was the PSA blood test, that the only way to find a prostate cancer early was to do the rectal exam. As I mentioned, the prostate sits right in front of the rectum, so a rectal exam if there is something like a nodule or a firmness there that could be a prostate cancer. But we now know that that test just does not contribute much above the PSA. So I want to be really clear. If your PSA is not elevated, it's not above the normal range, it's unlikely that we're going to find a prostate cancer by doing that rectal exam. And I like that this is becoming a moot point and being published, because I see plenty of patients that if I don't do the rectal exam, they'll tell me, well, aren't you going to do that? Like, what kind of doctor are you going to do that? Right? As if that's kind of a rite of passage. Yeah. So if you don't get that exam done, if the doctor's not doing it for you, that's because that doctor's just doing what the most updated research shows. You're not being shortchanged. Okay, so that's fact number one. Fact number two came up earlier. Just because your PSA is elevated does not mean that you have prostate cancer. This is a screening test. It tells you that you have a higher risk of prostate cancer, and then it thus should get more evaluation. And that's why after you have an elevated PSA blood test, you get sent to a urologist like me or one of my colleagues. Other reasons that the PSA might be elevated are just kind of benign overgrowth of the prostate that happens as man ages, or some inflammation in the prostate that could be just totally asymptomatic. You might not even feel it, and that can raise the PSA. We have ways of protecting that and dealing with it to prevent you from going down the whole rabbit hole of looking for prostate cancer. Okay, not all people with an elevated PSA need a biopsy. I'm going to go on that in the next slide. And then I also want to say, not all prostate cancer needs to be treated. That goes back to the earlier slide looking at stage. You have a small, low-grade prostate cancer. The most common recommendation is actually surveillance for that, because we know that treating low-grade prostate cancer just doesn't always benefit men. So we very often keep men on a surveillance protocol where we're just checking the PSA, we're doing MRIs or biopsies, and they can go 5-10 years without needing any sort of treatment. So again, we're doing this in a much smarter way than we were in the early 90s and 2000s. We're just treating and diagnosing everybody. Okay, so now I mentioned not everyone who has an elevated PSA needs a biopsy. And why is that? Because again, we're doing things very intelligently. You get an elevated PSA, the first thing a primary care doctor is going to do is recheck that PSA, double check that that is a correct measurement. And that right away clarifies a lot of things. It takes a lot of people out of that road going down to go see a urologist. So say you have two PSAs that are elevated, then you will go see a urologist. As a urologist, I implement a whole nother blood test, usually. And I also perform or recommend what's called an MRI, the prostate. And that gives us a roadmap of the prostate. If your additional blood test is normal and your MRI is normal, you don't need a biopsy. So we just put you back into the pool of the regular PSA screening. So that, again, saves a lot of people from needing a biopsy. If you have two elevated PSAs, you have an abnormal additional blood test and an abnormal MRI, that's who gets a biopsy. So again, many steps are saving people so that we can encourage people to get screened for prostate cancer and not worry that they're going to get a ton of workup unnecessarily. Okay? Does anyone have any questions about that?
Well, I do.
Yes.
I have a family relative, my family, but seemed like he was 90 years old when he was tested. And he had prostate. They did something, I don't know whether it was a screening or prostate, whatever, but he went downhill after that.
So it's this is a really great point that I like to bring up, in particular to prostate cancer. I think that sometimes it can be very tough to compare your situation or someone you know, their situation to another person's situation, because I would just guess that your friend might have been diagnosed with a metastatic late stage prostate cancer at that age. If he went downhill as a result of the cancer. So perhaps due to someone that could have benefited from screening, 10, even 20 years earlier. But I don't know, right? And so it's difficult to compare when you don't have all of that information. So it's tough.
If your PSA test shows you the normal range and you have a finger check or something, at certain ages are where you'd say, well, don't worry about it. Just one. At certain age.
Right, so we know PSA naturally goes up with age. So we actually adjust the PSA for your age. So if your PSA, if you're a 75-year-old, your PSA is 3, that could be normal. We don't have to go down this whole road. If your PSA is 3 and you're 45, that's not normal. And you should get checked out for that. So we do have smart, intelligent ways to kind of adjust to that. Okay, let's see, we're getting to the end of the road, so we keep the discussion going, but I'd just like to reiterate this slide that shows you that if you screen the right patients in the correct age range, use the test appropriately, you do the additional tests that I talked about in the last slide, by the time you're actually treating people, you should be treating a smaller amount of people that actually benefit from it. And that's the current state of things, 2024. Okay, I put this here because I think this is a common question about prostate cancer prevention. Unfortunately, there's not a lot of good evidence for things out there. There've been a lot of studies on this, and if you go to a store like a GNC or a similar store, you will find something that looks like any of these 3 products here that promote prostate health. And unfortunately, there's nothing that really does it. Unfortunately, I just like to put that out there. If patients come to me and they're already on something and it makes them feel happy that they're doing something, fine, it's not going to cause harm, but there really isn't anything that has been shown as a supplement that can help.
Is there any evidence that someone who is a heavy red meat diet, would that contribute to potential prostate?
This gets at a really good point that I want to break down and why the evidence is weak. If you Google, you will find a study that looked at that question and found a connection to prostate cancer. But the problem with those studies is, say they have someone that in that study ate, 5 pounds of red meat a week. I would bet you that person also had other things going on in their life that they can't control for the study. For instance, like they're eating that much meat, maybe they're not exercising so much, and maybe they're also smoking, and it could be these other things that are having an effect. So if I'm talking to someone about prostate health in general, I will tell you my recommendations are right here. Exercise and eat healthy to maintain a normal range of weight. There's no specific diet. If you're eating healthy and you're not overeating and you're exercising regularly, maybe you're going to that Benjamin's gym and getting your workouts in, anything that's promoting normal weight and exercise is going to be good for your prostate. And finally, I put this on here because this is probably the most well-studied thing, is more frequent ejaculations seem to be connected with a lower risk of prostate cancer. What that number is, no one can really tell us, but certainly in absence of ejaculation, it's probably worse for getting prostate cancer. Oh yeah, play this video. This is my 2-year-old when she was 1. All right, what's this? Back when I matched into residency, someone gave this prostate doll. So now it's my daughter's doll. She calls him Mr. Prostate. Okay, wonderful. That's my family right there. This is my business card. If you put your phone up there, you get there are all my contacts right there too. contact me anytime. This is my work email. This is the office phone number. I have a website, with a lot of patient information, and I post on X quite a bit, all things related to prostate cancer. So this is how you arm yourself with that knowledge or spread it. Thank you all for your time. This has been a real pleasure. Thanks for having me. Issue about prostate health and cancer. What are some of the other issues that confront as they get older that you might want to hear about? Yeah, so you're talking about the benign issues and the things that lead us to have urinary symptoms as we age, right? So my wisdom for that is urinary symptoms and related to benign prostate growth are totally dependent on a patient and their experience. And I like to put that out there that if one person is getting up 3 times a night to go urinate, that could be totally normal to them, and they're okay with it, and they're accepting of that. But to another person, that could be very upsetting and very alarming, and it totally throws off their life. So dealing with benign prostate growth is dependent on you. There's no normal cutoff for these symptoms. It's just up to you. If you don't like getting up 3 times a night, go talk to your doctor about it, start a medication, or talk about a procedure with a urologist. If you feel like your urinary stream has gotten weak and it takes you, 10 minutes just to start the urination and another 5 to finish, it's a long time in the bathroom for a quick bathroom trip. Some people are okay with that. Others are not. It's totally up to you. When we base our treatment, we base it on what is bothersome to you. Is that help? Yeah, because I heard with my physician, there is a drug you can take that reduces urine creation during the night. So there is some medications that will help. So in particular, urination overnight, if I could just give you my tips now. Yeah, outside of medication. First thing that I recommend is for all men, and if women have this issue a bit less commonly, but if they have, this is still holds better. Right before getting into bed, I recommend going to urinate. No matter what, for any guy. That right away can help right away. Can help a number of people reduce the number of times they have to urinate overnight. That's number 1. Number 2, in addition to that, what I recommend is actually urinating twice before going to bed. We call that double urination or double voiding. So you go urinate and you do something else for a couple of minutes, like brush your teeth, whatever is your normal nighttime regimen, and then you try to urinate again. You can find that you can actually empty your bladder a lot better that way. So those are the first 2 tips. Third tip, without any medication, is don't drink anything 2 hours before your usual bedtime. And I like this tip because I think a lot of people out there they hear this 8 cups of water a day, which that really didn't come from anywhere. It's kind of a nonsense myth in medicine. We have thirst for a reason. It tells us very well when we should be drinking. So I like to recommend you go to sleep at 10, stop drinking water or any fluid around you. It's okay to, of course, have a sip of medication. And if you have a medical issue that you have to stay extra hydrated, like kidney stones, we actually recommend that, then that makes more sense too. But typically you don't have to drink for 2 hours before going to bed. Yes.
This has the prior slide.
Yes.
Is the incidence of prostate cancer higher in celibates, for example, Catholic priests?
So the way that they did, these studies was more based on survey results. So it would be, just a normal person filling out a survey about their frequency of intimacy compared to those who had lower or higher.
Okay, it's the general survey.
Yeah, so if no one has looked at, for instance, people who remain celibate. And
Okay.
This is a general question.
Yeah.
But I've heard that, seems to be that doctors go through medical school younger, have a lot more knowledge and techniques, whatever it is, than ones who went in the 80s and 70s. I mean, if you're younger, but you shouldn't go to an 80-year-old doctor because he just doesn't know as much.
Here's my opinion on this, okay? My dad was a general surgeon, and he retired just a couple of years ago a year into the pandemic, and so that would be completed as training in 1985. And of course, we continue our medical education after our training. We have to. That's part of law, how to maintain your licensure. But I do look at, my role as a younger physician as kind of advancing the field and making sure that when a new concept comes along that can actually help patients gets, we call it propagated. So when we learn that, for instance, in the past 10 years, MRI certainly helps us with finding prostate cancer and also not digging for prostate cancer that's not there. I mean, I felt like part of my role there was to promote new research on it and get that propagated. Is there a problem going to an 80-year-old urologist? Probably not. In fact, I have a good mentor at UCLA who's in his 80s. He's at a point in his career where he doesn't do surgery. He's not working, he's not taking out prostates anymore, but he did. And he served a large number of people in the 80s, 90s, and early 2000s. He did do that. Do I think that I'm any better of a doctor than him? No, I can learn a lot from him. But I think he also knows that working with me, he can learn some things too.
All right, last question, Gordon.
To what extent, if any, do you think that insurance reimbursement, Medicare, et cetera, affects practice?
So it's a tough part of medicine. I guess I'll first start off saying that I'm very thankful because I'm working at a safe place like Cedars where it's academic and I'm hired as an academician researcher. So my salary is not dependent on me seeing and doing like the most expensive things on patients. So I feel very thankful for that, but you can't deny that people are motivated by that reason. I think if I had to put one thing out there, it's in prostate cancer that I get hesitant about. It's the focal therapy for prostate cancer. The focal therapy is when they use laser or they freeze or another technology to just zap that tumor without taking out the whole prostate. I think there's a role for that for some patients, but I think that it gets unfortunately overused for a lot of patients. And I think that that's motivated by the reimbursements.
All right, before you conclude, I may have a silly question.
Oh, no, not with the urologist. They know jokes.
You've heard over the years that the chemical makeup of tomatoes
Yeah.
lessening symptoms or is that a wise tale or is that any truth to it?
This is a good one because this one has been evaluated really well. This one, vitamin E, vitamin D, selenium, all have been evaluated really well for prostate health and prostate cancer, and unfortunately, no connection.
So no action.
Red beans and Chris. You all red beans you want, you can put some ketchup on it. You enjoy ketchup.
No.
The A1 guy.
Thank you so. Speaking of Ben and the rest of them, I hope that sometime in the future, we would love to have you come back and give us a little bit more insight.
Of course, yeah, anytime.
All right, we have a speaker skip for you. Thank you.
And so much.
Next meeting will be September 5th. Father Travis Russell, president of Verdum Dell High School. Verdum Day, thank you. We are dismissed.